first I'm going to have all of our panelists introduce themselves. So Bill, would you start?
Good morning. My name is Bill Bushka with the Oregon Health Authority. The Oregon Health Authority is the state agency that is responsible for the health system across the state and includes the Oregon Health Plan, but also public health and a lot of other state agencies that are integrated into one large agency. And I'm an innovator agent, and I work closely between the Oregon Health Authority and a few CCOs around the state.
And I'm Frank Moore. I'm with Linn County Health Services.
And I'm Rebecca Austin. I'm with Lincoln County Public Health.
Good morning, everyone. I'm Tatiana Jerwechter. I'm the Healthy Communities Manager at Benton County Health Department.
And good morning, Kevin Ewinchin. I also just previously introduced myself, but I can't remember if I stated that I am also with Intercommunity Health Network as Chief Medical Officer.
All right, thank you. So our first question that we wanted to ask our panel was and we're going to start with Bill on the end, to describe the CCO model. That's the coordinated care model for the state of Oregon.
So just a little bit of background on coordinated care organizations. How many people feel like they're have some understanding of coordinated care organizations in Oregon? All right, excellent. So the coordinated care organizations have been up and running for over 3 years now. And it's important just to step back just a second and to just what is a coordinated care organization and the coordinated care model. Prior to 2012, we had a system, and the coordinated care organizations are really focused on the Oregon Health Plan population. Today we have over 1 million people on the Oregon Health Plan across Oregon. We've had a substantial increase in the last few years. But a large majority of those people, up to 95% of the people on the Oregon Health Plan, are enrolled in coordinated care organizations across the state, and that there are 16 across the state. And really the promise of the coordinated care organizations is really about 5 different components that are really important to think about in the coordinated care organizations. And the first one being integrated and coordinated care. Prior to the coordinated care organizations, we had 4 or 5 different managed care organizations that administer the health care benefit for the state, for the Oregon Health Plan. And that was really just set up administratively and really sliced a person up into lots of different areas. So you have this organization that's responsible for dental, this organization is responsible for mental health, this organization is responsible for dental care. And by the way, there's a whole bunch of other stuff that are part of the Medicaid benefit that the state administers, and that is really part of fee-for-service. And really, nobody locally really pays very much attention to that. It just kind of happens. And so we had this fragmented system, lots of inefficiencies and ineffectiveness, spending lots of money where we didn't really feel great about the outcomes. So really integrating and coordinating care is one of the basic tenets of the coordinated care organizations, and including all the different health services and different things like non-emergent medical transportation, which is part of the coordinated care benefit also, and a bunch of other things that the state continues to give the CCOs to administer for us, and we're happy for that. There's also a global budget, so all of the money basically going into one budget for the coordinated care organizations, and the hope of a fixed rate of growth for the CCOs. We have lots of incentive metrics and metrics that we measure the effectiveness of the model and effectiveness of how we're doing as a state to the federal government. So we're really looking at different outcomes and not just paying for how many services somebody provides or how many services somebody gets. So you don't have stories like the story that Dr. Ewinchin told at the beginning. Increasing amount of flexibility, not as much flexibility as we would like yet, but really trying to reduce a lot of the limits on services that are provided and the kinds and places that services can be provided. And really importantly is local accountability and local governance, and have a governance structure that is set up for the coordinated care organizations across the state.
Thank you, Bill. So I'm going to follow that question up with a question for Dr. Iwancina. I'm hoping that you can describe for us the service area of the IHN CCO and the governing structure of the CCO.
I'm going to test this microphone. If we get feedback, I will shut this one off and use that one. We were getting a little bit of feedback earlier. But before I go into the IHN CCO, which is our coordinated care organization in Linn, Benton, and Linn County, I wanted to follow up with what Bill was saying. One of my favorite things about coordinated care organizations is the ability now to interact with all of our public health departments and our public health officials and our community members and our members that are overseeing other nonprofits looking at social services. We all knew of each other before, but the CCO gave the platform to come together, to look at this from a shared model, a shared level of responsibility. And that up to date is one of my most favorite things about the CCO movement. Intercommunity Health Network CCO is the CCO that's been present in our 3 counties, Linn, Benton, and Lincoln County, since the development of CCOs in the year 2012. We're actually one of the first CCOs, and we decided to become a CCO because of the strong history of collaboration to date when we were just part of the Oregon Health Plan. Intercommunity Health Network was an agency at that time that was delivering Medicaid services. But as Bill alluded to before, the distinct services were very fractured and divisive, meaning physical health entities were different from the delivery of the mental health services, which were different from the institution of the dental health institutions. So our partnership today cares for over 65,000 Oregon Health Plan members residing in Linn, Benton, and Lincoln County. And this is collaboration now between Benton, Lincoln, and Linn County governments, local health care practitioners, federally qualified health clinics, Accountable Behavioral Health Alliance previously, Capital Dental, the Corvallis Clinic, independent physicians like Quality Care Associates, the Oregon Cascades West Council of Governments. I could go on and on and on, but we're just hearing a few of those resources that are now all part of the CCO. And the CCO does not act independently. We have a board of directors that oversees the operations of Intercommunity Health Network CCO. This is comprised of the president and CEO of Samaritan Health Services, but 2 independent physicians that deliver care to our members. 2 county commissioners are on our board of directors. 1 county administrative officer. We have a hospital administrative executive that's on our board of directors. We have 3 community members from the community for the community that are on our board of directors. And then we also have the chair of the Intercommunity Health Network Community Advisory Council that is on our board of directors. And that's the makeup of the governing body that really oversees the day-to-day care that we deliver to our Medicaid members in our 3-county region.
Very good, thank you. And now I'm going to ask our public health partners if they would, and Frank, if you want to start and just pass down the microphone and talk about the services that public health provides.
Well, I'd actually broaden that a little bit from public health, and that public health, depending on how you define it and what arena you're in, it changes. Public health, in my mind, is within the department in Linn County, is one of several programs. There are respective programs for alcohol and drugs and mental health alongside that, as well as programs for individuals with developmental disabilities. Public health does, however, take the lead when it comes to the community health improvement plans, or has historically, which is the, I would wager, the area that Tatiana and Rebecca are going to probably speak to most specifically, and that's been an historic role. That as part of our intergovernmental agreement, the county's intergovernmental agreement with the Oregon Health Authority under the Public Health Division, to really begin looking over time, doing community health assessments, determining where the inequities and disparities exist, and begin to create a framework or a structure that looks forward in terms of the future and how we resource public health, mental health, alcohol and drugs, and other services within the community. It's also something that public health entities under the intergovernmental agreement with the state have been doing now going on at least for a decade, if not longer. It's where the Oregon Health Authority appointed coordinated care organizations.
Environmental health departments in public health, which has always been kind of a misnomer, the way they name it, because we have very limited abilities to address environmental issues, and the asthma and mold issue is a perfect example where we get calls pretty much daily, I would say, living on the coast, of conditions people live in with black mold, and we have no resources for them. We have nothing except for to refer them back to their, usually landlords, to try to correct the problem. So that's a very sad thing, because you know that these people are already living in horrendous conditions, don't have many supports, are struggling, and we can't really help. So our environmental health is mostly focused on safe drinking water, which is a big deal, and making sure that when you go to a restaurant to eat or a hotel to stay in, or that you're swimming in a pool that's safe for you and that you won't get sick. And then we also do home visiting. That's when nurses or paraprofessionals go out into the home and work with pregnant or parents of young children. And so that program has been going on for years, I think probably 30 or 40 years in Oregon. It's very strong. It gets good results. But again, I think if we could begin to address some of those social determinants, if we could make sure that people have a healthy place to live, decrease the levels of depression, we could even get better outcomes, because I think moms that are depressed really hinder us getting really good outcomes in those home visits. And then let's see what else. Why don't you talk about health promotion?
Well, excuse me, the only thing I would add is some of the changes that Rebecca just described over the last decade, both at the federal level with Centers for Disease Control and Prevention's new focus on social determinants of health, and some of the changes in our region. Public health in general is moving from a direct service kind of model, particularly in health promotion, to a health policy kind of focused model. And it's completely changing our workforce and the kind of people we recruit to do this work. If you call the Benton County Health Department, you won't get anyone who will come and probably staff your health fair, because it's really something that's shifted in terms of who in our communities are already doing that, and really using our staff now to help around convening community conversations, helping the community look at data and interpreting that, and what does that mean for our neighborhood or our families, helping to support planning, alignment, just like today, and having partnerships that come together around very targeted work. And so that's something in each of our 3 public health departments. We're on a journey. We're all in different places, but in general, that's a huge new emphasis in public health.
Thank you, Tatiana. We have, as the CCO, we have learned so much from our public health partners, and I can't say enough about how graceful they have been as they've watched us learn and given us the patience to understand the broader perspective that public health brings to the health of a community. On that note, they, and I think Frank mentioned, they all have a community health improvement plan supported by a community advisory council. And I think one of the things that we did early on as a CCO was utilize those community advisory councils to build our community advisory council. And that has resulted in a lot of alignment in our community health improvement plans across the 3 counties. And so, Bill, I was wondering if you could talk a little bit about the community advisory council requirements and the expectation from the state level.
Thanks, Kim. It was really important at the state level, as we've talked about this coordinated care organizations really becoming the potential for a lot of money going into them. They control all the health services in the systems and in the regions where they are housed. And from the state perspective, it's really difficult for us to have that accountability, to really watch what's going on all over. So it's really important for us, and one of the key parts of the model is local governance. And part of that local governance structure are the community advisory committees, councils across the state. And there are quite a few across the state and doing lots of great work. I told Frank I wouldn't get too much into the CAC that's here, or CACs that are here, but there's one in each county and a regional. So for any of you, there's plenty of opportunity to get involved in the Community Advisory Committee. I think, in thinking about the Community Advisory Committee, why it's important and why it's important for the CCO, the CCOs are really beginning to get more and more involved in community health, and becoming more and more important is the health of their members. Because again, we're not focused on paying them for how many services they provide or for their high cost services. We're trying to align the incentives so the money is aligned to keep people healthy and to do as much preventative care as possible. In some communities, about 40% of people living in a community could be enrolled in the coordinated care organization. Some smaller, more rural towns, it's a majority of those communities that are enrolled in the CCO. So there's lots of incentive for that work on the health of the community. But the community advisory councils are described in statute, and they're described in the contract that we have with the coordinated care organizations, and they really must be representative of the community that the CCO serves. So that equal representation of geographic and the different qualities of the population that are served. And the goal is to have a majority membership of those community advisory councils to be consumers of the Oregon Health Plan and people who use the system. And that's a really important value, is that people who use the system are really drivers of those groups. The councils have to meet on a regular basis, at least every 3 months, and have some sort of public display of their meetings. Either the meetings are totally public meetings, or they need to be posted online and information available. Some of the really important duties of the CAC are really overseeing the community health assessment process for the CCO, and adopting a community health improvement plan, which we'll talk in some more detail in a little bit. And really that community health improvement plan just provides that strategic guidance for the CCO. So the community advisory councils really help set that strategic platform for the CCO to meet. And the CACs also work with the CCO to publish a report of the progress of the Community Health Improvement Plan. So that's kind of the overview of the CACs, and I work with multiple CCOs, and I'm sorry for all the acronyms. I work with multiple coordinated care organizations, and you guys have a great community advisory council system and really active membership. So again, I'd really encourage you to get involved if you're so inclined.
And we have several of our CAC members here. Would you stand up if you're on the CAC and you're here? Very good, thank you. I'm going to ask Frank to talk a little bit more about our CCAC and the structure and how it was developed. Frank was a part of the regional steering committee that put the CCO together in the very beginning and decided it was going to be it was going to cross a 3-county area, and that IHN, the historical IHN, was going to be the vehicle in which the CCO would move forward. And then he was also instrumental in the structure of how the CAC was formed and the development of the regional CAC. So Frank, do you want to talk a little bit about that?
Sure, I'll be glad to. And I'm going to back us up just a little bit, and you can dope slap me on the break if you want. I think it's important from when we take a look at, and we had a conference call last Thursday to kind of talk about this, but I noticed that there's a number of people in the audience that are also part of the behavioral health provider community. And what I do want to say is that while it says public health on the agenda, and public health has spent much of the last 20, 30 years working on issues of prevention and health promotion, in Oregon, up until the advent of coordinated care organizations, I think it'd be a fair statement to say that, at least on the mental health side and to some extent on the alcohol and drug side, the notion of prevention was, from a funding standpoint, was an oxymoron. And so as we talk about this, we're not just talking about the social determinants, but I think the other thing that's an important factor for you to consider is no matter how much we throw at people with mental health, mental illness, or substance use and abuse problems, no matter how much in the way of resources and money we throw at those individuals, if they don't go home to a stable home or a roof over their head and a meal, to some extent we're wasting our money. It's not a good return on investment. I think that's a no-brainer for most people, but I want to make sure that people understand when I come at it, I'm coming after it, all of that, and I think it builds on the strengths of public health and the work in behavioral health, not to mention oral health, but that's the focus that I come at it from. In terms of the Community Advisory Council, we started out, you may or may not know that each county in the state is required historically under statute and Oregon administrative rules to have a health advisory committee, a local alcohol and drug planning committee, a mental health advisory board, a developmental disabilities advisory board, and on and on. There's a number of them, but actually the only one that spent that much time with a community health improvement plan is public health. As we began to envision where we wanted to go with this, with the influence and the support and the resourcing under Medicaid and the Oregon Health Plan, with the Community Advisory Council and working with the CCO, the idea was, okay, well, how do we capitalize on the traction that we already have in communities, and how does that begin to feed and help with the broader tri-county regional Community Advisory Council's work? And the predominant piece of their work is to do a community health assessment and ultimately to advise the coordinated care organization on the health impact areas that they believe, at least at this point in time, will be most relevant, most pertinent to the work of the coordinated care organization in advancing the health care for the region. Some of the things that we looked at, quite frankly, begin to take a look at, it shouldn't make a difference what side of the river you're on when you're pursuing physical health care or behavioral health care. If you're in Albany, it doesn't make a difference if you go to North Albany and Benton County. The quality, the type of services or the access, all of that should be equal. So basically what we did was we capitalized on the local groups and formed a Community Advisory Council, which has 18 members, plus an additional member, which is the chair of that advisory group. Out of that, a majority of those individuals, they either have to be Oregon Health Plan consumers, Oregon Health Plan eligible, or we've also stretched that to include a family member or parent of somebody who's Oregon Health Plan eligible. So we do have representation primarily of people who are provided services under the Oregon Health Plan and under the Coordinated Care Organization. So we have 19 individuals at the regional level, but we also have somewhere between 15 to 20 in each of the counties that work in concert and in support of the work of the Community Advisory Council. And I think that's the beauty of it. We have local traction. And one vantage point, quite frankly, we have a coordinated care organization that is a community-based, homegrown organization. People who work at the coordinated care organization live and work right alongside the rest of us. I think that's one of the values that we've espoused as part of putting this together, and I think we followed through with that value when it comes to fielding a group of citizens and providers in each of the 3 counties which work in concert with the coordinated care organization at the regional level. So it's not just 19 individuals or 18 in a chair. You're actually looking at somewhere between 85 to 100 individuals across the region which have come together to put together the community health improvement plan that we have right now. They have to be refreshed every 5 years. We're about 2.5 years into it. We've just done an update and are recommending that we, being the Community Advisory Council, we've just done an update. We're recommending and refining based on the health impact areas that we've worked on to this point, and it's an iterative process. So we'll be back at this multiple times, but in my mind, it's probably one of the first times that we've begun to see all entities that are promoting healthcare, both financially and from the future of our communities and our citizens come together, and I think that has happened under the CCO model. It's played a catalytic role, and I've been doing this going on 37 years. Until the advent of coordinated care organizations, as Dr. Iwancina said, we all knew each other, but we played in different sandboxes. And I think what we're doing now is probably one of the biggest advancements in the healthcare industry in my 40 years.
Thank you, Frank. Dr. Iwancina, can you tell us how the CAC and the Community Health Improvement Plan that they have developed has influenced the work of the CCO?
Sorry about that. So, yes, one of the biggest areas of focus for the CAC, the Community Advisory Council, was really this collaborative effort of utilizers of the Medicaid plan, the Oregon Health Plan, and really listening to those constituents in forming the health impact areas of the Community Health Improvement Plan. We really needed to understand the needs of our members, of our community, and have that flow forward through the 3 regional community advisory councils to the larger parent community advisory council. And in its first community health improvement plan, this community advisory council had recommended, and the CCO did accept, the following health impact areas as these priority areas for an improvement plan. And these were all really revolving around these 4 domains: access to healthcare. First, having insurance, having Medicaid does not always equal access. So how is the Community Advisory Council going to give recommendations and direction on improving access to that healthcare? Next, we've already heard about the importance of behavioral health. And even though I'm a physical health provider in family medicine, I would say that family medicine was always steeped in behavior change and behavioral health too. And that's one of the great things about the coordinated care organizations, is that we get to put back the human brain back into the human body and look at it from all aspects. Behavioral health is key, and there's been studies showing time and time again that if a person has poor behavioral or mental health, they will have more chronic diseases. If you hear about ACEs, adverse childhood experiences, this is a finding that trauma experienced in childhood can predict a person having more chronic diseases or poorer health as they become an adult. So as we're looking at the importance of behavioral health in the health impact area, it's very important to keep this at the forefront. Chronic disease was another health impact area. It's not enough just to have that diagnosis of chronic disease. Let's call it chronic obstructive pulmonary disease or emphysema. How do you build community supports around that individual with that chronic disease? How do you build coordination of the care? How do you communicate during transitions of that care so that all are on the same page regarding that chronic disease? And how do you best modify it so you have the best outcomes and hopefully decrease the cost? And then the last health impact area of the Community Health Improvement Plan was maternal and child health. And this is really preventive health at its very, very beginning. Healthy moms, healthy babies, healthy communities.
Thank you. So Tatiana and Rebecca, I'm hoping that you can share how you feel the addressing social determinants of health can affect the CHIP outcomes as the Community Health Improvement Plan outcomes Dr. Iwancina just described.
Well, you both did such a great job describing social determinants of health that I won't do that again, other than to have you take to heart the visual that's on your table and flip it to the other side as well. I actually just want to share an example of some work that has come out already in the last 2 years between public health, mental health, and our CCO around this idea of how do we link social determinants of health with primary care and health care. And it came from some funding that I think, Bill, you directed us to. That was the first time that the Oregon Health Authority released funding for mental health promotion and wellness, as opposed to to mental health treatment. And through our collaborations over the last couple of years, all 3 public health departments, mental health departments, and the CCO collectively applied for this funding and were awarded it. Last year, we used a public health framework called the Strategic Prevention Framework to spend a year looking at our data, looking at all the qualitative work we had done in this area, and it's actually not that much because this is a new kind of conversation in the country, and then conducting key informant interviews across the whole region. In Benton County, we're going to be adding some youth voices and youth surveys this spring to it. And probably won't surprise you, when we analyze the needs assessment results, there was actually very little discussion about mental health services. There certainly is a need, and definitely culturally and competent, linguistically appropriate mental health services. But the vast feedback was about the social determinants of health. And just some of the key areas, we've mentioned these already: trauma, toxic stress, ACEs, family and community violence, social isolation, racism, housing, food, transportation, employment, income, education. These were all the things that our assessments showed that if we can make progress in these areas, we can dramatically impact mental health and wellness in our communities. And so I wanted to highlight the other Bible of visuals that we use in public health is the socio-ecological model. I keep threatening my daughter I'm going to have a little tattoo put on my shoulder someday, my first one. Because a lot of times our interventions focus on that individual level. We put a lot of resources at the top of the triangle, right? And it's important and it's critical. But the list I just gave you requires different kinds of solutions. For example, education. In Benton County, affordable childcare, we have twice the cost of Linn and Benton counties. Transportation, we have a great OHP-covered transportation system, but to help people be included in their neighborhoods and involved in social networks, we need OHP coverage to help people get to a park, to help be involved in social activities, to be able to contribute and volunteer in their communities.
So Tatiana, I was just going to expand on that. For people who don't know, the CCO does cover non-emergent medical transportation for individuals, but currently that's limited to transportation to a medical appointment. So at this point, it doesn't cover transportation to get housing vouchers or to look into housing or to go to a grocery store, that type of thing.
Yeah. Great example. Food, reducing barriers to SNAP and food stamps. Housing. If every one of us in this room were involved in educating our policymakers in February during the legislative session about the need for inclusionary zoning, this is the group to do it. We have the distinction of being the only state next to Texas that doesn't have that in our state. And it's a huge policy lever to help create affordable housing in our community. Lots of examples. So think about how that list I just shared creates different kinds of potential solutions. And as we move into our small groups this afternoon, to be thinking across sectors and who are the partners that need to be a part of those conversations.
Thank you. Rebecca, do you have something to add?
Oh, let's see. So I just wanted to say that the Community Health Improvement Plan is a really community-based process. And so in Lincoln County, we actually, when we brought all of our interested community members together to work on our Community Health Improvement Plan, we all recognized that housing was one of our biggest problems on the beach. And so we put that in our Community Health Improvement Plan. We had no idea how we were going to address it or how we could fix it, but we thought it was important enough. And so anybody can go and Google health and housing, and you'll just come up with all these resources about really the linkage is just critical. And I don't think public health could do anything as fabulous since the seatbelt, really, to improve health than we could with housing. I just can't get over it, and how excited I am that you're all here and that the Federal Reserve is here and that they're on our side. It's so thrilling. So that's all I wanted to say. I mean, really, it's like from the very kernel in Lincoln County, this small little rural community struggling, all the way up to the Federal Reserve Bank that's really rooting for us. So it's exciting.
Very good. Bill?
I just wanted to add something about the community health assessment process and the community health improvement plans. There are lots of them, and there are lots of them that are required in federal statute or in state regulations. The CCO, we've primarily been talking about the CCOs, but the county health departments all have a process and a plan that they have to create. There's multiple ones around. The hospitals all have to do one also, so it gets confusing pretty quickly about which one are you talking about. But the importance is that more and more communities are driving alignment in all of those assessment processes and all those plans. So those of you in the community don't get crazy making about, oh, which one are they talking about now? And so I think in time you'll see more and more alignment of all of those plans, and that's one of the reasons why the Federal Reserve Bank is here, to help get that alignment and bring some of all those plans together. If everybody's concerned about a community health, and then everybody that can do something about community health and create plans should be at the same table together, moving it forward as much as possible. There are some regulatory restrictions, but just to keep that in mind when we're talking about it, there are multiple plans and it gets confusing really quickly. It's just today, that's kind of the way it is.
Thanks, Bill. And so if for today, if we can all make just for purpose of conversation and our focus today, if we can say that improved housing would improve the 4 CCO CHIP focus areas: chronic disease, maternal and child health, help me here, I forgot the behavioral health, right, and access, right. If we make that assumption and we let that to sit with us today, so my question then, the last question for the panel is, what are the areas of opportunity for cross-sector alignment that would result in our ability to improve those outcomes through better housing?
Well, I think I could speak to that, and you're not quite yet privy to the information, but actually, as part of the outcomes and indicators work that Rebecca was involved in, Bill was involved in, and the community advisory councils that, quite frankly, Rebecca Fowler, who's the community advisory council coordinator, gets to ride herd on. We did a lot of work in refining those health impact areas, and we actually separated them into 5 because we think that it's of that much importance. And that's behavioral access to care, behavioral health, chronic disease, child health. We separated that out, and maternal health, because we felt that there was of that much importance in terms of how we begin to pull that information together. The other piece that, and it's always good to hear somebody who's got bank in the part of their title. That means there may be money around the corner. But I think one of the things that's happened locally that's made a big difference is that Benton County has taken a lead on what we call the regional health alignment. I don't know what we call it. It's a team or a task force. I didn't really want to do that because when I get annoyed with them, I shorten it to Regional Health Alignment Team, which is RAT. And I didn't think they wanted that unless we're in a new year, and it has some relationship to Oriental calendars. But I think that what that represents is that as part of the Regional Health Assessment Team, all of the entities have contributed financially to support an ongoing effort that will be moving forward that's goal is to align the CHIPs and the CHAWs of the 3 counties in the region, and hopefully it will be factoring in the health, the hospitals, CHIPs, and the work that's been done historically with public health. But that's what will build into a product that hopefully at some point down the road, my dream is 2 to 3 years down the road, we won't have multiple planning efforts. They will all reside in 1 or 2 community health improvement plans that will have a place for everybody, every discipline, and obviously every disorder, but most of that is forward-looking and aligning the effort. But that's been a local investment that the CCO and the counties have contributed, and the Council of Governments have contributed to. I think that's what makes it work.
I guess I would just share from Benton County's experience, housing and transportation are 2 of the key priority areas in our CHIP that we identified 3 years ago. And this has been a really wonderful experience for our community because it has forced public health and mental health providers to start learning about housing and transportation. And has forced us to learn new languages in the areas of community development and land use planning and transportation. And I would say for those partners, they have learned a lot about how do you engage communities, How do you make sure all voices are at the table? How do you make sure you use data to really address disparities? And it's been a wonderful synergy, and some exciting work is coming out of that. And so one of my hopes for this day and the future work in our next few years with our CCO and our region is that we can scale that up and do that regionally. We have wonderful leadership across many different organizations. We have the Council of Governments. Teresa's here. Is she here? One of our coordinators for our Albany Metropolitan Planning Organization. She's part of this journey, helping us to learn about their world. And I think that there's great opportunities to share those experiences and expand that across the region, build our capacity to talk these different languages and do the shared work together.
Very good. So Dr. Inuwachena, I probably most of you don't know, but he is still a practicing physician. He mentioned he still has his certification, but he didn't mention, I don't think, that he works every Thursday as a practicing physician. So I'm going to call on him to give us that physician perspective, because on the IHN CCO, I think it was Rebecca had mentioned that we're trying to get all of our members to see a primary care physician, and for that to be their center to ensure and to then wrap services around them to ensure that we can maximize their health outcomes. And so from a physician perspective, what alignment or what understanding or what awareness do they need to help make connections with the housing issue?
That's a great question, and I will speak on behalf of my colleagues. I may be the only physician that's in the room right now. So where are all of our other physicians right now? They're seeing patients. And they're seeing patients in a system that has allotted 10 minutes to 12 minutes per patient. Not because of generating income for themselves, it's because the need is out there. Instead of seeing a person 6 weeks out, they're trying to get people in as quickly as possible. That increases the demand on practices today. And I bring that up only because the model of one patient, one physician is still very in place. And one of the great opportunities of the coordinated care organizations, the collaboration between our public health partners, is really looking at redefining what primary care is all about. It's about a medical home. It's about a team. And you need that team to be aware of information. So as a physician, if I'm looking in my electronic medical record and I'm seeing an updated diagnosis or problem list, a medication list, an allergy list, specialty records that may or may not be there at times because the EMR is still pretty well in its infancy, one of the things that would still allow me to get a better picture of the person in front of me is a social determinant of health inventory. But in that 10 to 12 minutes that I have with that patient in front of me, and I'm also supposed to be asking about their depression and screening, brief intervention, referral for treatment for drug or alcohol abuse, and I'm supposed to take care of their diabetes, and I'm supposed to take care of their COPD, and I'm supposed to take care of their hypertension and talk to them about all their other screenings, you can see why the conversation of the social determinants of health is just not present in today's setting. But if there are other partners and agencies that are already collecting that type of information, what is the best way that that information can feed to a primary care team so that that team is very aware of the needs of that individual? And how does that team then help make those resource linkages to give the best type of care from a community perspective to those individuals? And that's where I really feel our future is trying to cross that bridge of that individualized care that we all need, and looking at it from a global perspective of the population and what is it that the population needs and how do we leverage others in the community to help us with that data collection and that information gathering.
I appreciate that. I was at a conference in November, and they were talking about how if providers were not just the PCP, but their whole office, if their whole office was doing all the data collection and measurement that they needed to do to meet all the expected quality measures that are out there from the federal government, from the state government, et cetera, they would be measuring 148 measures per physician. That's a lot of measures. And so one of the things that we need to be thinking of is how do, and on the flip side, when we go and we talk to physicians, they're like, if I just knew what was going on at home with this patient, I could help. So one of the things we need to be thinking of is how do we communicate that to physicians in a way that doesn't overburden an already overburdened office and system. So any other thoughts on that from the committee or the panel?
Oh, gosh, no, okay. So one of the other key findings that came out of that mental health promotion project I was telling you about was, it was probably the #1 theme that came from families and individuals was the challenges they face in navigating complex systems. And when you think about when we're dealing with the issue of housing, most of our folks have probably experienced a lot of the other social determinants on that list. They're often, it's stressful, there's a lot of trauma, and we expect them to figure out this whole complex system. So I think part of the team needs to be new kinds of care coordination, health navigation, universal care management, case management models that support the whole medical home, the whole neighborhood, the whole village, if you will. We have examples of that in places in our region. We have best practices that show that this works. And so that's another area I think we can do some new investment in the coming years.
Bill?
The only thing I would add is that we know across the state that over 60% of the people enrolled in the Oregon Health Plan have a chronic disease, a chronic medical condition, and that has been the case for a very long time. And if we're going to change people's lives and change the health of people's lives, we really have to get out in front of that chronic disease model and people waiting till they're sick and the system waiting till people get so sick that they have to go to see somebody to help them, whoever that ends up being. But we have to get on the other side of that, and we have to get to more of a preventive focus and really more of a collaborative focus so that systems are working together in a more organized manner. The CCO can't do everything. They're really primarily around the provision of health services, but they are really concerned about the health of their members and having their members be more healthy. And that's why collaborations like this are so important, that we have to bring health to where people live, and people live in their homes, or people live where their stuff is. And having that as a healthy place as possible is really important. And it's really important for all of us that center of health gets closer and closer to where people are and gets closer and closer to that individual. So we have that accountability for our own health, but we have to live in reasonably healthy places to have that health also.
Very good. Rebecca, did you have our last comment?
I do. I just want to say that I was reading about this sort of new term for me. It's called neighborhoods of opportunity. So that's another thing that you could Google if you want. Kind of real exciting grassroots sort of approach to is kind of the basic is that it's mixed income communities, and they're seeing just great results. Talk about outcomes improving. Stressors go way down, so that means that we're not as likely to get a chronic disease. Children are not, they're much more stable, so they're going to the same school. They're not moving as much because of that, because there's a lot of more supports, more amenities in those communities. And I think the adolescent depression rate in one of the studies I looked at was reduced by 11%. So in my community, that would be like cutting it in half. So that is huge, and I really think that that's where the action is, and that's where we all sitting in this room can contribute.
Very good. Thank you. And thank you for our panel. Let's give them a hand. So we're going to have our healthcare panel come down and our housing panel come up. And while they do that, if you want to take a few minutes to get some more coffee, take a break, or just have a conversation at your table about what you just heard and any aha moments that you can take from that.